This is Blood and Cancer, the official podcast of MDH Hematology Oncology. I am the voice of MDH Podcasts, Nick Andrews. And welcome to episode 72 of Blood and Cancer, the official podcast of MDH Hematology Oncology. I'm joined this week, as I always am, by the editor-in-chief of MDH Hematology Oncology, Dr. David Henry. And Dr. Henry, under normal circumstances, this would be a rather exciting time for clinical hem-onc. Everyone would be gearing up to take vacation days or make some schedule arrangements to head to Chicago and look into the latest research in clinical oncology for ASCO.
What do you mean? It's not in Chicago?
I heard that there might be something going on.
Oh, I have to cancel my plane. Well, sadly, you are right. Actually, it's creating some interesting problems for the weekend because we would all be in Chicago, but of course, we're all going to be home. And when you're home, things come up.
Yeah. Walk
the dog, fix the garage, go out to Home Depot and buy something else that gets you through the COVID era. So I've set aside as much as I can Saturday and Sunday. And my understanding is actually it is Saturday and Sunday, not morphing into Monday, Tuesday, which it usually does because there's no educational sessions, just scientific presentations.
Yeah. It's I'm interested to see how it goes because from what I understand, this will be one of the biggest specialty meetings that's happened under these circumstances, specifically in the Western Hemisphere. So I'm really fascinated to see what people think about it, and maybe parts of it can be online from now on. Are we going to miss the social aspect? I'm interested to see what people's outlook is.
I think it will change the future, but it remains to be seen how well this goes. And I think it's actually going to go well. They've put a lot of time and effort, and we'll see what the membership likes and dislikes.
Yeah, absolutely. But before we get to introducing our guest this week, Medscape, who is owned and operated by the same parent company as MDH, we know we've partnered with them in the last year or so, just completed its annual physician survey, and there's some interesting findings regarding physicians in general and oncologists. So I just wanted to kind of take your temperature. I did not prepare you for this. I kind of wanted to hear your honest reaction. So 76% or 77% of physicians said that if they could do it all over again, they would still become physicians. And 96% of oncologists said that they would choose oncology again. Where do you land on those?
Isn't that interesting? Okay. I'm certainly in the 96%. I really love what I do. And I remember when I first moved to the neighborhood and our kids were young, and you'd meet people at cocktail parties and, what do you do? Well, I'm a banker and I'm a social worker. And, Dr. Henry, I'm an oncologist. They'd say, oh, that must be just so awful. And after a while, I would respond like, no, it's great. And they would walk away. So after a while, I had to say it's terrible. But actually, it's wonderful because win or lose, we help our patients. And certainly in this new decade and century, we're helping more and more with all this translational science.
Yeah, absolutely. No question. You can find the complete results to the survey, including salary comparisons by specialty and something interesting, the biggest challenges for being a physician / biggest challenges for your specialty. Majority of people said rules and regulations, so that's interesting findings. You can find that at in our show notes as well as at Medscape and on MDEdge as well. We'll be covering those results for some time. It's interesting data that we like to look in year to year. So got some interesting updates this year from one of our favorite guests. Dr. Gradishar is back, and that means we're talking about what's new in breast cancer.
Well, he's a wonderful thought leader in breast cancer, and he's going to be awfully lonely in Chicago, his home city, this weekend. So we thought we better feature him to make him feel that we all haven't forgotten him. And since we're not coming to Chicago, and we talked about breast cancer, and timely, the interview occurred just a couple weeks ago of a couple of studies that had just come out and or published in New England Journal and or approved by the FDA. So the first we talked about was the HER2 CLIMB study, this tyrosine kinase inhibitor TKI, Tucatinib, which was just approved as we did the interview, in combination with trastuzumab and capecitabine in HER2-positive breast cancer. In particular, patients on the study had or didn't have brain metastases, and there was a significant help and positive effect on those women with brain metastases. We talked about another HER2-positive new drug from the DESTINY trial. Here's a drug antibody conjugate to trastuzumab called deruxtecan, and this also had in fact, I have a patient myself on this trial. This drug is also approved, the trade name Enhertu. catchy title,
Yep.
that has positive results in HER2 positive patients who have failed other HER2 positive therapies. And then we finished up with triple negative breast cancer, which may be as many as a third of our patients, and in the neoadjuvant setting, in the Keynote 522 trial, pembrolizumab with or without a chemotherapy backbone, or I should say the chemotherapy backbone with or without pembrolizumab, and the combination was much more effective.
Yeah, and obviously a lot of movement in the past 5 years, 10 years, 15 years in some of these therapies, but just the fact that there was an approval, like I think it was within 12 or 24 hours of the interview, is really kind of timely stuff and very exciting to be treating this. Yeah, absolutely. So, like I said, we're going to be covering ASCO as it happens online, which is pretty exciting, but stay tuned for our interview with Dr. Bill Gradishar and everything that's new in breast cancer. Dr. Henry, thanks so much for joining me once again.
Thank you, Nick. Everybody enjoy ASCO.
I'm Dr. David Henry, your host today on Blood and Cancer, our weekly podcast, which airs on iTunes or wherever you get your podcast from each Thursday morning. We're also on our electronic journal called mdh.com/hematology-oncology, where you can find this episode, along with show notes, which our wonderful young house staff, when they're not doing COVID work, are doing show notes on the podcast we're doing today and on ones previously done in archive. So we encourage you to go to the site, and we welcome your comments. So I'm delighted today to take a little time out of his busy schedule as being a hospitalist. I just learned of Dr. Bill Gradishar, who's a wonderful thought leader in Chicago in breast cancer, where he is the Betty Bramson Professor of Breast Oncology, Chief Hematology Oncology, and Deputy Director of the Robert H. Lurie Comprehensive Cancer Center in Chicago at Northwestern. So, Bill, thanks so much for joining us today.
My pleasure.
So, of course, we're recording this on Friday, April 24, and everyone's very, very busy with COVID, but I thought we want to keep a little bit of our Blood and Cancer podcast going to keep our education going, because one day we'll focus back on nothing but oncology. And the San Antonio Breast Conference, of course, every year in December in San Antonio is one of the bright lights on what's happening in breast cancer. And we're going to talk a little bit about HER2 metastatic and triple negative neoadjuvant, but wanted for the listeners to highlight what Dr. Gradishar just did on VUMEDI, VUMEDI. It's a wonderful series of lectures on very current topics, current authors and current information. Bill talked about adjuvant therapy in HER2, the Catherine trial, Affinity trial, and the Attempt trial. And so I encourage you all to listen to that and others on VUMEDI. But today, Bill, wanted to talk to you in brief about some HER2 metastatic. And the first one I wanted to ask you about is the HER2 positive breast cancer phase 3 metastatic, called the HER2 CLIMB trial. And if I had it right, and you can correct me, the patients had to have previous HER2 therapy, trastuzumab, pertuzumab, TDM1, and then they were randomized in this phase 3 trial to get trastuzumab again with capecitabine, plus or minus this really neat new tyrosine kinase inhibitor, Tucatinib. And so how did that trial go?
So we're being very, very, very current, because this drug just got FDA approved in the last 48 hours. And
I didn't know that.
Next thing we have available. In fact, both of the things we'll be talking about today with respect to HER2 have resulted in FDA approvals since the San Antonio meeting. So most hospitals don't have Tucatinib in yet, which is the area we're talking about first. And Tucatinib is an oral TKI, and it is a very potent drug. And the other thing that is attractive about it is it appeared to have some activity in the brain. But we'll step back a little bit and just talk about the data that led to its approval, which was, as you pointed out, the HER2 CLIMB trial. And this was a randomized trial in patients who did have prior anti-HER2 therapy, and specifically trastuzumab, pertuzumab, and TDM1. So these were patients that had been exposed to all of the drugs that we think of as particularly active in HER2-positive metastatic disease. And then another important thing was patients could have had brain mets. And when we talk about trastuzumab deruxtecan, which is the other drug that was approved, they also allowed brain mets, but in contrast, this trial not only allowed stable brain mets, but active brain mets that not necessarily were treated before. So there is a bit of a distinction, and it's important when you look at the data. So anyway, as you pointed out, the randomization was trastuzumab, capecitabine, and placebo, or trastuzumab, capecitabine, and Tucatinib, which is the drug that we're most interested in. And when you look at the data from this trial, it demonstrated very clearly that the addition of Tucatinib made a big difference with respect to outcome in terms of not only improving progression-free survival in favor of the addition of Tucatinib, but there was also evidence that it had a similar effect in those patients who had brain mets as well. So I think that these data, and again, if you were to specify in very concrete terms what was the additional benefit, PFS improved by a couple of months, median overall survival improved by about 4.5 to 5 months. So clinically meaningful. And then, as I mentioned, the thing that intrigued people is that you were actually seeing an improvement in PFS in those with brain mets. And with respect to one of the things that we always worry about with TKIs is often the frequency of significant diarrhea. And, grade 3/4 diarrhea was very, very uncommon in contradistinction to neratinib, which is a drug that you have to use immediate antidiarrheal measures as you start the drug. So my guess is that this drug will be used. The upside is its activity in the CNS. It is approved as a triplet, so it requires Tucatinib, capecitabine, and trastuzumab. So it's a more complicated regimen, but nonetheless, it's had an impact, and I expect it'll be used.
Oh, I actually can think of a patient right now, and I'm so glad you mentioned the lack of diarrhea. A couple of my patients on neratinib, I think the full dose is 6 pills, and they said no way. They got to like 2 or 3 and had to stop at that level. And I should mention this, and the next study we're going to talk about, both appeared in this famous February 13 New England Journal 2020, February 13 issue, if listeners want to go to more data. So continuing the theme of HER2-positive metastatic disease, there's the phase 2, and I think a phase 3 is underway, Destiny trial. And here is trastuzumab with this, I think it's a topoisomerase inhibitor, deruxtecan, and in these patients who had at least 2 prior HER2 therapies. And so what were the data there, and was this impressive?
Yeah, so you can think of trastuzumab deruxtecan, or DS-8201, as a drug similar to TDM1, or commercially known as Kadcyla, in the sense that it's an antibody-drug conjugate, an antibody, in this case trastuzumab, hooked on with a linker to a topoisomerase 1 inhibitor. And what's different about this, say, compared to TDM1, is there's more of the payload attached to the antibody. So almost double the number of chemotherapy molecules compared to what you would see in TDM1. And the other thing that's interesting about this drug is there is the so-called bystander effect. And I think we're now beginning to appreciate that oftentimes tumors, not surprisingly, are heterogeneous. Obviously, they're HER2-positive disease. Some cells are HER2 negative. And this bystander effect that's been observed is that not only are you targeting HER2 disease, but you have the effect of when the payload is released, it can have an effect on cells that are not HER2 positive. So this makes it attractive as well, without necessarily increasing the toxicity. So there is a phase 3 trial, more than one ongoing, but the phase 2 trial was impressive enough that it led to a provisional approval by the FDA. And this was a trial, as you said, the Destiny trial. Patients who are HER2 positive, they had prior TDM1 therapy. And although there was a dose-finding element to the trial, it was largely a phase 2 trial in patients with TDM-resistant or refractory disease, a couple hundred patients. And beyond the TDM1, all the patients had gotten trastuzumab, 2/3 had gotten pertuzumab. and a variety of other therapies as well. So again, this is a pretty heavily pretreated patient population with respect to HER2-positive disease. And when you look at a waterfall plot of the results, that's what got everybody's attention, because you want to see everything responding. And there were actually, the vast majority of patients responded. There were only a handful that did not. The response rate in this heavily treated patient population was 60%, including 11 patients who had complete responses. So the drug is real. It does work, and it's quite potent. And with respect to side effects, even in the early development before this trial, one of the things that got people's attention was there was the emergence of some patients who experienced interstitial lung disease.
Mm-hmm.
So there was a lot of attention paid to this in the phase 2. And again, this was a trial conducted across many different countries. And it appeared that the ILD, although we don't have clear defined risk factors for who develops it, it did seem like there were more patients of Asian descent who may have gotten it. And there were, in the trial, actually 4 patients who died of interstitial lung disease.
Really?
So there is a black box warning that you have to be aware of. And I think what we can say now, even though there's a lot more work being done, is you have to have a lower threshold for people who have respiratory complaints, and that was even before COVID, to really be thinking, could somebody on trastuzumab deruxtecan be expressing symptoms that are related to interstitial lung disease? If you're concerned about that, there may have to be dose interruptions, modifications, obviously assessment of the lungs with the scan. We haven't experienced that yet, but again, we haven't treated that many patients. But those that we have, not on trial, just since the drug's been approved, have responded. So it looks like a good drug. And I guess one of the obvious questions, this will probably fall in the space post Herceptin, pertuzumab, and TDM1. How are you going to choose between trastuzumab deruxtecan and the Tucatinib regimen?
Right, yes.
And they'll be competing with one another. But, you know, if you had somebody with clearly active CNS disease, Tucatinib may be, you know, a more appealing choice. We just don't have enough data from trastuzumab deruxtecan, although there were patients in the trial with CNS disease that was stable.
Well, it's really impressive. With, I think, if I recall from the paper, he had to have at least 2 prior therapies, and the median was 6. And for that kind of response rate in heavily pretreated people, really impressive. So then the third trial of 3, wanted to ask you about switching to neoadjuvant, or it was neoadjuvant. It's the Keynote 522 in triple-negative breast cancer. So a really bad tumor we all don't like to see because it tends to be more aggressive. And here, the setup, which I'll let you explain, was Taxol carboplatin, also later on an anthracycline and Cytoxan, and with or without, in this particular case, a pembrolizumab checkpoint inhibitor. So how did these people do? And for our listeners, this was also a New England Journal publication, February 27. How did these people do neoadjuvant-wise?
Right. So in the breast cancer world, checkpoint inhibitors, immunotherapy have been a little bit slower. Obviously, we have atezolizumab in metastatic disease for PD-L1 positive patients. Pembrolizumab was evaluated in this trial to see if it could enhance the PCR rate, pathologic complete response rate, preoperatively, and it did indeed do that. And if you look at the data from the trial, the hardest thing you can say is, you know what the PCR rate is, obviously, because the patient goes to surgery, and it was significantly improved. It was essentially 65% in those who got pembro added to the chemo, and 51% in those who got more standard chemotherapy. So there was a delta there of 14-15%, which is significant. And what we always look to neoadjuvant trials to hopefully demonstrate is by impacting on PCR, that's a surrogate for what will happen in the bigger picture, event-free survival and overall survival. And
did PD-L1 matter here, Bill? Did they need to check whether or not it was higher or lower in between?
I'm sorry, what was that?
The PDL, did they need to know whether, before using a checkpoint inhibitor, did they need to know whether or not it was tumor burden, mutation burden, or PDL1 status?
No. So they did not. So it was different than the data that emerged from the atezolizumab trial, where only PDL1 positive patients benefited. And here, the event-free survival is short. I mean, we only have follow-up at a median of about 18 months. There's a numerical trend favoring pembrolizumab translating into improvement in PFS, but it's still short follow-up. So I know when this was discussed and deliberated at the one of the recent NCCN conference calls regarding whether this should go on the guidelines, we were still a little bit hesitant based on the short time that these patients have been followed. Certainly, if you look at the endpoint of PFS, does it improve? I'm sorry, PCR. Does the addition of pembrolizumab improve PCR? It's pretty clear it does. Now, whether it'll translate to a long-term effect remains to be determined.
Well, all three really interesting and exciting trials. It must have been a great San Antonio conference for breast specialists like you attending. And wanted to finish up with a case, and the theme of this case is, do we always need an Oncotype DX or some kind of genetic testing? And what to do if someone sent it and it comes back? So this is a 46-year-old premenopausal woman, had a right breast lumpectomy, small, a T1B 7 millimeter size, grade 1. Infiltrating ductal, ER positive, HER2 negative. And so discussed at tumor board was whether or not to send an Oncotype DX. And I think NCCN for T1Bs grade 1s says you don't need it. It was sent and it came back 21. So could you decode this? Do you need to know genetics on a patient with such a good prognostic set of parameters? And what do you do when it comes back in that magic 11 to 25?
Yeah, so this is a hard one, and it proves the point that don't order a test you don't want to live with the results from.
Yeah.
And you get in trouble. I'm not suggesting there's trouble, but it turns into a result that it's somewhat difficult to interpret. So we would consider chemotherapy, for tumors above 5 millimeters. The other characteristics of this tumor were all favorable. I guess the only thing that must have triggered the use or getting the Oncotype was the age of the patient.
Yes.
Because the other features were all favorable, and we would have probably been more inclined to recommend endocrine therapy alone. I would still say such a patient, even with the Oncotype test, it falls into that category under 50 with the score between 21, 25. There might be some additional benefit from chemotherapy. The overall risk of this patient recurring is quite low just based on the size of the tumor alone. And, how much additional benefit you could achieve above and beyond endocrine therapy, even with that score that suggests chemotherapy is going to be helpful, is going to be very modest. So I think this would be post facto sort of a discussion with the patient. Now that you have this result, do you want to discount it, and are you willing to tolerate probably 4 treatments with TC, docetaxel cyclophosphamide, or depend on most of the other characteristics and the size that is going to tell you the vast majority of patients like this are going to never have any problems with the disease again. And I guess it would depend on how risk averse that patient was.
Exactly. And then, of course, you factor in, as I'm having more and more discussions with treaters in various tumors, even doing these podcasts, then add in COVID and trying to keep people away from treatment centers and myelosuppression. And I think we may have time for this last one, I thought, which is, do you need an Oncotype when we're the other end? And so here we are, a 57-year-old postmenopausal woman, grade 1, 10 millimeter, ER positive, HER2 negative, but 4 out of 17 lymph nodes positive. Is this someone who this pushes us to chemotherapy, or do you think the Oncotype would have utility here?
Well, again, I would, most of the data, well, number one, we don't have definitive data with Oncotype and node positive disease. We have a number of different trials, registry data, all kinds of data, even, an old SWOG study that suggests that the Oncotype can demonstrate differences, even if you're node positive, and help you make decisions. But the place where I would use it in the absence of the exponder trial, which isn't yet available,
Right.
is in patients with lower nodal burden. And for me personally, that starts to get into micromets or a couple of nodes at the most. When we're up near 4 in somebody who I would still view as relatively young with 4 positive nodes, I would be more inclined to err towards chemotherapy than not. And I think this would be one where if I had an oncotype test, that it would make me a little bit unsettled, even if it was low, because, most of the data we have isn't with, 4 positive nodes.
Yeah. So I and our tumor board thought exactly the same thing. So well explained by you. Well, I really appreciate you taking the time, Bill, to talk to us and your busy life there in Chicago, and particularly with this COVID. And to remind our listeners, we've been speaking with Dr. Bill Gradishar, who is professor of medicine at Northwestern University Feinberg School of Medicine, where he's chief of hematology oncology and the deputy director of the Robert H. Lurie Comprehensive Cancer Center. We will be posting this shortly, and you can listen to it wherever you get your podcast called Blood and Cancer. It's also going to be our electronic journal website called mdh.com/hematology-oncology. And Bill, great thanks again to you, and hope you and family and friends and colleagues stay safe in Chicago.
Same to all of you and all that are listening. Stay safe.
Thanks so much, Bill.
And that concludes episode 72 of Blood and Cancer. Blood and Cancer is produced by the editor-in-chief of MD Edge Hematology Oncology, Dr. David Henry. Dr. Henry was also the host of this week's interview with Dr. Bill Gradishar. Blood and Cancer is produced by the editor of MD Edge Hematology Oncology, Jennifer Smith. All MD Edge podcasts are produced by our editor-in-chief and the editor-in-chief of Medscape, Dr. Ivan Oransky, as well as MD Edge executive editors Mary Ellen Schneider and Kathy Skarbeck. Multimedia editor Terry Rudd and Kyla Clark produces our social media. I am your audio engineer, audio editor, and the voice of MD Edge Podcasts, Nick Andrews.